There's a moment every therapist dreads. Your client is using drugs or alcohol, clearly suffering, and quietly tells you, "I'm not ready to stop." What you do next can deepen their despair or change their life. Hi, I'm Dr. Andrew Tatarsky, clinical psychologist, founder of the Center for Optimal Living, and pioneer of Integrative Harm Reduction Psychotherapy. Over the last 30 years, I've helped thousands of people transform their relationships to drugs, alcohol, and other compulsive behaviors, often after traditional programs told them they had to fail before they could be helped. If you're a therapist wondering whether you could make a bigger difference in the world, then this may surprise you. Right now, more than 48 million people in the United States meet criteria for a substance use disorder. That's 14% of the population. But the real number is much larger. Another 100 million Americans live with patterns of substance use that don't meet the diagnostic threshold, but still cause significant harm. If we include the 100 million more who struggle with compulsive behaviors like disordered eating, gambling, porn, social media, out-of-control sexual behavior, shopping, or gaming, that's over 240 million people in the United States. That's the majority of the adult population, and a significant percentage of your practice is comprised of them. And yet, many therapists still say, "I don't work with addiction," or only treat it from a narrow abstinence-only model that doesn't really reflect the complexity of their clients' lives. Here's the single most important point. The number one reason people with problematic substance use don't seek help is because they don't want to stop. The next most common reasons, stigma and lack of access. And yet most addiction treatment in our culture continues to say, you can only stay in treatment if you commit to stop using. Imagine telling people with depression, you can only stay in therapy if you agree to stop being depressed. That's how absurd it is. That's not care. That's a barrier. And that's what we need to change. So here's the hard truth. Most treatment programs fail not because the clients are not motivated, but because the system doesn't meet them where they are. Only 10% of people who suffer with problematic substance use get into treatment. Less than half of those who do get treatment complete it, and about half of those relapse within the first year. That's only about 2% of people struggling with addiction who succeed at the stated goal of abstinence-only treatment. And over the last 20 years, over 1 million people in the United States have died of lethal overdose and drug poisoning. Our field has pathologized ambivalence. We've prioritized compliance over connection. We've taught therapists to wait, watch, and hope, instead of engage with skill and compassion. That's why I developed Integrative Harm Reduction Psychotherapy, or IHRP, as a new clinical roadmap to success. Integrative Harm Reduction Psychotherapy, or IHRP, is a clinically tested roadmap built on 9 therapeutic tasks. IHRP is supported by a shift from understanding what we call addiction as a disease to recognizing it to be a multiply meaningful response to suffering that reflects an interplay of the psyche, the body, and relationships that is unique to each person. IHRP adapts these therapeutic tasks that you know well to the needs and challenges of people who struggle with addiction. The first task is create absolute safety and alliance. Second, enhance self-regulation with mindfulness and somatic tools. Third, work with the urge, because the urge is the axis of change. Fourth, use assessment as treatment to spark curiosity. 5, clarify and address the multiple meanings of substance use. 6, embrace ambivalence. Don't pathologize it. 7, set harm reduction goals clients can actually own. 8, strategize and experiment for real-world success. And finally, this may be one of the most important keys to success. Manage countertransference so our reactions can heal, not harm. I'd like to show you exactly how we move a client like Tom, who arrived at my office too drunk to finish a sentence, to Valerie, a mother who was trapped in a painful dilemma. She loved injecting Dilaudid, and yet she was terrified of losing her children. Or Sarah, who engaged in life-threatening alcohol and cannabis use that she successfully moderated when we treated the trauma that was driving it. In this video, I want to focus on one of those 9 tasks, embracing ambivalence. When a client seeks help, the part of them that wants to change, to stop or to cut back their substance use, is leading the way. Traditional approaches work only with that part and ignore, or worse, demonize the part that still wants to use. But this sets both therapist and client up for failure because the part that wants to use is a vital part of the person that holds important information about what the use means to the client. Because remember, in IHRP, we see addiction as a meaningful response to suffering. If you take the time to listen to both the part that wants to change and the part that wants to use, you can conceivably help the client create a constructive dialogue between the parts that can lead to a plan that the client is more likely to follow. If you don't include the using part, then it's likely to feel left out and subvert the plan and keep doing what it was doing. Picture this. Tomorrow, a client comes in, admits that they used last night, and says, "I'm scared, but I'm not quitting." Instead of feeling dread, you feel calm. You know exactly how to keep them engaged, reduce risk today, and guide them step by step towards sustainable, positive change. That's not wishful thinking. That's the clinical confidence IHRP delivers. If you're thinking, that's the kind of therapist I want to be, the one who stays grounded, connected, and effective, even when a client is actively using or ambivalent about change, then I'd like to introduce you to a training I've developed specifically for that purpose. It's called Integrative Therapy for Addiction and Compulsion, a harm reduction approach. This course brings together the core principles and therapeutic strategies that I've refined over the past 30 years. So you can step into this work with clarity, compassion, and real clinical skill. You don't have to reinvent your practice. This training will complement your practice with the right structure, language, and tools to help your clients take meaningful steps forward wherever they are on their positive change journeys. Let me tell exactly what's included when you join. When you join the training, you'll receive immediate access to a complete, self-paced online course built around the 9 therapeutic tasks of Integrative Harm Reduction Psychotherapy. You'll start with 7 high-definition video modules where I walk you through each phase of the model, from establishing safety and alliance to working with urges, building motivation, setting real-world harm reduction goals, and developing comprehensive strategies for achieving them. These aren't abstract lectures. Each lesson is designed to give you practical, clinical, applicable skills you can begin using with clients right away. Along with the core training, you'll also get downloadable worksheets and client tools, including urge surfing, optimal use plan templates, and assessment scripts. Case studies from my own practice that you can see how I apply these principles to the messy realities of working with addiction. Lifetime access, including future updates, so you can return to the material anytime on your own schedule. And for those who complete the training, a certificate of completion that you can display and add to your professional credentials. And yes, continuing education credits are available for those that need them. The value here goes far beyond what I've listed. If this course helps you support even one client more effectively, if it gives you one tool that prevents a dropout, a rupture, or a relapse, if it restores your confidence with clients who have historically shut down or shut you out, then it's not just valuable, it's essential. Can't I just refer people with substance use issues to treatment? Well, treatment resources are scarce and either underfunded or too expensive for most clients. And as I said before, traditional treatment methods have a very poor success rate. Is harm reduction just enabling? This is one of the most frequent questions that I get, or concerns that people have. No, enabling is doing for a client what they can do for themselves. Harm reduction is equipping them to choose any positive change, and science shows it saves lives. My licensing board expects abstinence. Boards expect evidence-based, client-centered care. Increasingly, the professional community is moving in this direction. IHRP is fully aligned with current best practice guidelines and trauma-informed standards. I'm too busy. Well, our modules are divided into bite-sized segments that are 10 to 20 minutes each. Apply the tools the same day. The time you save by reducing dropout and relapse will astonish you. I became a therapist to lessen suffering, not to watch it cycle back session after session. And I know you feel the same. When clients sense that we finally see them without judgment, without ultimatum, the room changes. Their shoulders drop. Often they break down in tears, and hope walks in. That moment is why IHRP exists. I'd be honored to guide you there. Click the button below and secure your spot now. Join me. Together we'll replace stigma with science, fear with compassion, and resignation with real, measurable change. I can't wait to welcome you inside.